Good day, everybody. Today, we'll just touch upon briefly about retinal vein occlusion management. In particular, the macular edema associated with retinal vein occlusion. As you all know, retinal vein occlusions are the second most common cause of retinal vascular disorder after diabetic retinopathy. So we day in day out in our clinics, we do see huge number of these patients coming for follow-ups and treatment of the new cases of retinal vein occlusions. So it's an important cause of blindness worldwide. And these conditions usually run a prolonged course. They need multiple treatment sessions, multiple follow-ups. So you'd be seeing the patient for quite long in your clinics once when they come with retinal vein occlusions. So what are the types of retinal vein occlusions? Of course, there are four main types. The main one is the central retinal vein occlusion, wherein the block or the thrombus is at the level of the lamina cribrosa, and that leads to quite a scary looking picture, which is blood and thunder appearance. Of course, there are different types like ischemic type, non-ischemic type, and each type will have its own course of presentation and the course of the disease. Though ischemic types are much more violent than the non-ischemic types in terms of presentation and the number of treatment sessions they need. The next type is the branch retinal vein occlusion, wherein we see a quadrant of retina being affected. You will see hemorrhages, cotton wool spots, and of course that will lead to the macular edema. Here, the block is at the arteriovenous crossing. And usually, again, these also run quite a bit of course. And it can either be supratemporal or infratemporal branch retinal vein occlusion. And sometimes the nasal branches can also get occluded. Hemiretinal vein occlusions here, sometimes in few of the eyes, the central retinal vein branches before it enters the optic nerve head. And so one of these can get blocked and have either a superior part or the inferior half of the retina being involved. And the other ones are the minor branch retinal vein occlusion, what we call as macular branch vein occlusions. When a small tributary in the macula gets occluded, that leads to hemorrhages, cotton wool spots, and that also leads to macular edema and a drop in vision. The causes for retinal vein occlusions most of the times are systemic, most of the diabetics, hypertensives. Then the ocular causes are, it could be primary open angle glaucoma. The other systemic causes like hyperlipidemia or obesity can also lead to these retinal vein occlusions. The pathophysiology is that once when there's a occlusion in the retinal vein, it leads to high capillary pressure because of the backflow, as well as that leads to capillary leakage and changes in the endothelium lining the capillaries. This will lead to ischemia and hypoxia, and the retinal tissue starts secreting out the vascular endothelial growth factors and other cytokines and other inflammatory modulators in the vitreous cavity. And that in turn sets up a vicious cycle wherein that leads to more leak from the capillaries, endothelium, and that leads to collection of fluid, macular edema, and that also ultimately leads to new vessels, wherein the mechanism by body is trying to divert the blood flow. And these new vessels are fragile and they can lead to bleeds and vitreous hemorrhages. And if they become fibrous, they can also lead to the traction of the retina. This is the whole pathophysiology of the retinal vein occlusions. Macular edema is the commonest cause of this pathology. Macular ischemia, vitreous hemorrhage, the other ones, like combined retinal detachment. This is a picture of an OCT where most of the patients will get an OCT done once when they have, and you can see the macular edema. The options for treatment we have is the anti-VEGF injections, steroids, intravitreal, and also laser. But laser of late has been less. Eylea aflibercept is one of the anti-VEGF, which is a unique molecule, small in size. Also, it blocks both platelet-derived growth factor as well as vascular endothelial growth factors. Ranibizumab, which is Patisiran now, and it's also since 2005 or 2006 we've been using it, FDA approved. Avastin is a non-FDA approved molecule, bigger, larger in size, but still the most widely used. Steroids are like triamcinolone, dexamethasone implants. These act for long, like 2 to 3 months, but they have their own side effects. Iluvain or fluocinolone has the longest acting steroid. So when you compare with anti-VEGF and steroid, anti-VEGF safer, first line, Steroids can cause raised IOP and cataract. So that is their drawbacks. So they are kept as second line acting, but they are long acting agents. Clinical trials, we have had quite trials like Bravo trial for ranibizumab and branch retinal vein occlusion. The mean injections that the patient received here were around 8.7. In Vibrant aflibercept, they received around 9 injections. The gain was quite good. For the CRO, we have Cruise, and Copernicus and Galileo were done for aflibercept. But in real life, they just, you don't get so many injections. So how do we balance it out? The best is to either go with the treat and extend protocol or the pro-renata, so that we give the best to the patient with a lesser number of injections. And treat and extend is most popular among the retinologists, where in the first 3 monthly, you give monthly injections. Later on, you keep on increasing by every 2 weeks, like 6 weekly, 8 weekly, then make it 10 weekly, 12 weekly, up to you reach around 12 weeks. So what we have found, our personal experience and the retinologists throughout the world is, since we cannot follow the randomized controlled trials, protocol wherein you keep on injecting monthly. So we found that, treat and extend is kind of the best balance, wherein you have lesser number of injections with best visual outcomes and maximum visual gain. And also the macula is maintained dry for the most times when you use this protocol. In pro-renata, the patient might drop out and might come to you late, may not have that continuous treatment and continuous flow. The macula may not be dry most of the times. So the overall results may not be as good as the treat and extend protocol. And also it's been seen that more the number of injections the patient receives, the better the outcome at the end of 6 months and 1 year. In fact, it's been seen that the number of injections that a patient receives in the first 6 months determines the whole course of retinal vein occlusion. So take home is that the anti-VEGF injections, of course, are the first line treatment for retinal vein occlusion, macular edema. As I said, the options are Eylea, aflibercept, the ranibizumab, Lucentis, or bevacizumab, Avastin. So all these three are equally efficacious. And of course, Eylea and Lucentis, the safety profile is much, much better because they come as a single use. Avastin, sometimes we have seen inflammatory things happening. And of course, there are now other molecules also, what we call biosimilars, like razumab or cobercept. These are different biosimilars. But again, they may not be consistent in their action and from batch to batch. Of course, retinal vein occlusions need quite a prolonged treatment. And of course, what we have seen is that more the injections the patient receives, better the improvement and better the outcome. And of course, what we have found is that the treat and extend is the best practical approach in these conditions, wherein the patient receives as less number of injections as possible with a maximal vision gain and the best visual outcomes. And in case if there are any non-responders or the suboptimal treatment, then of course the steroids are the next line of treatment. Yeah, thank you.